for today's presentation, these are some of the objectives that we will be trying together to accomplish. One is identify and screen the children that are exposed to trauma. Also, understanding the role of pediatricians to support the recovery of these children and families who've been impacted with traumatic stress, and various interventions that we can apply while addressing the trauma in children and adolescents. So first we go into, before we diving deep into the trauma interventions or other treatments that we can offer, we go over the definition of trauma. So as per the National Child Traumatic Stress Network, which is one of the well-known network across the nation, and you can certainly search their website as well. They have a lot of resources available on their website. The traumatic event is defined as any frightening, dangerous, or violent event that pose a threat to child's life or body or bodily integrity. Or it can also be defined as witnessing of trauma event that threatens the life or physical security of loved ones. So really important to keep in mind that either the traumatic event can happen to the child themselves, or they may have witnessed or heard the narrative of that can have great impact on the safety of their loved ones. So these are some of the key definitions used to explain trauma. Potentially traumatic experience, any event that causes or threatens harm to the child's emotional or physical well-being. That is potentially traumatic experience, which we continue to assess when we do the visits with our pediatric patients. Next is a child or traumatic stress, where is intense fear or the stress response that occurred after a patient experience of a traumatic experience, and it can overwhelms the child's ability to cope. And the third thing is acute stress disorder. Basically, now we are getting into more disorder pathology where the PTSD-like symptoms appear, but the traumatic event happened less than 30 days. And many times this acute stress disorder may resolve with the safety and support. In other cases, it may progress to PTSD. And now what is PTSD, which is intrusive thoughts, avoidance, hypervigilance, negative mood, which persist beyond 30 days after a trauma incident has happened. And then there is something called complex trauma as well, which you might hear the term, which include exposure to multiple chronic traumatic experiences, abuse, betrayal, loss of family members or loved ones that disrupt the bonding and development. And these happen over time, multiple times in their lifespan. And adverse childhood experiences are abuse, neglect, socially impactful experiences, household dysfunctions, poverty, homelessness, or any other community adversities like neighborhood violence, linked to long-term health outcomes, physical or mental health outcomes. Those are adverse childhood experiences, also called ACEs. And if you look at the DSM-5 PTSD criteria, so it's not just experiencing a traumatic event will cause PTSD in everybody. And we'll talk about the prevalence later on as well. And how do you define PTSD? Criteria A is that there needs to be a certain level of exposure to either some traumatic events, such as death or threatened death, actual or threatened serious injury, actual or threatened sexual violence. Either it could be a direct exposure, or as said before, could be a witnessing the trauma, or it could be a narrative heard, like they could have learned that something happened to their close family or friend who was exposed to trauma. And then indirect exposure could be aversive details of the trauma, usually in the course of professional duties, such as could happen in first responders or medics. Like it may not be happening directly with them or with their loved ones, but happening in the context of what they do every day. So these DSM-5 criteria are for children above 6 and above, and then they have slightly different criteria for children 6 and below. So we'll go into details about that. So this is criteria A. And the other criteria are experiencing intrusive symptoms, which is one or more of any of those, such as unwanted upsetting memories, flashbacks, nightmares, could be avoidance, one or more, where they don't want to talk about those or disengage from pleasure activities and avoid activities that may remind them of the trauma, or feeling kind of like feeling numb around certain things. And the other one is having two or more of negative alterations in cognition and mood, which basically they don't, for example, could be they don't remember the details of anything that happened, or they might blame themselves, or feeling kind of like a decreased interest or negative affect, feeling isolated, or difficulty experiencing positive affect. So any of two will be required to make the full criteria. And then the last one, E criteria, is alteration in arousal and reactivity, which may include any of these, such as they may have more irritability, more aggression, risky or destructive behavior, hypervigilance, startled reaction, difficulty concentrating, difficulty sleep. All these criteria that we talked about and these symptoms lasting more than 1 month will qualify for PTSD. And you also have to see that how it is affecting the day-to-day life of their patients. Like in children, it may be affecting their academic functioning, ability to enjoy social activities, engage in play, outside with friends, things like that. And then also need to make sure that symptoms are not related to any medication use, substance use, or other illnesses. This DSM-5 criteria basically changed in 2013. DSM made a significant changes in which they moved some of these criteria items from one category to another. But for PTSD, initially they used to be under anxiety disorder, but now they are classified under trauma and stressor-related disorder. So they have their own separate category now. So other key changes included like more clearly defining the criteria A, which we just talked about, and then adding a fourth type of exposure in criteria A, increasing the number of symptoms, symptom groups from 3 to 4 by separating the avoidance into a different own group. So total number of symptoms go from 17 to 20. Some of the wordings got changed, and they also added a little bit of a different criteria for children age and 6, which are more developmentally appropriate. And there are different specifiers also, acute and chronic. And then if there is a dissociative feature also associated with the trauma, that is also one of the specifier with the PTSD. And acute stress disorder, if someone experiences acute stress disorder, which I talked about, is a symptom experience within the 30 days, that person may have a higher chance of association of PTSD later on. About half of those with acute stress disorder ultimately develop PTSD, but there are many who do not meet full criteria for acute stress disorder, but eventually they end up developing PTSD. So there could be sometimes also called delayed PTSD, which we'll talk in a little bit, in which a patient may not experience any acute stress disorder, but as they come to remember the details of that traumatic event, they may end up developing PTSD later on. So what are the things that are common to adults and youth with PTSD criteria? Again, timelining is one thing. And then PTSD diagnosed is, like, as I said, has to have symptom as traumatic event happen and the symptoms are persistent after 30 days. That's when you diagnose PTSD. Not like, hey, event happened a week ago and suddenly patient has PTSD. That won't be PTSD. That's like acute stress disorder. Uh, Three main types: re-experiencing of trauma, such as intrusive, distressing memories, flashback nightmares, avoidance, increased arousal. Those are the common things that are seen in adult and youth. And if we talk about PTSD in preschoolers may have less ability to clearly relate events or process their emotional reaction, and they may not show an overt initial reaction. And one must still assess the child when there is a reported trauma. And children may be able to express trauma in different ways, such as one of the DSM criteria they made the change is play reenactment. So in children, the trauma can be expressed through the play rather than verbally expressing how they are experiencing the impact of trauma. And PTSD in youth under 6 is the presence of one or more of the followings. Definitely, the intrusive thoughts are still there for the under 6 as well, but you have to see that they may not be able to directly tell I'm having nightmares or I'm having flashbacks or other intrusive thoughts, but it can appear more in the play as a play reenactment. Distressing dreams can be there, but it may not be possible. The dreams could be just frightening dreams. It may not be exactly what the trauma they experience, but any content the clinician have to make the judgment call if it's related to trauma, or it could be just frightening dreams that may also indicate that the child is experiencing distress because of the trauma they have experienced. And then reaction as if the traumatic events are reoccurring, and the most important being loss of awareness of the present surroundings. And another is intense or prolonged psychological distress to internal or external cues, and marked physiological reactions to reminders of traumatic events. If they experience any increased heart rate or other emotional reaction, which we'll talk in a minute. So, in regard to children, these are some of the things that are still found in children younger than age of 6, in which persistent avoidance of activities or places of physical reminders, people, conversations, interpersonal situations that arouse recollection of the memories, diminished interest in significant social activities such as play, socially withdrawn behaviors. So these are some of the avoidance behaviors that you may be able to see in children younger than 6. And two or more of the following can be present in regard to mood and arousal symptoms, which is anger, irritability, hypervigilance, startle response, problems with concentration and difficulty of falling asleep or staying asleep, and is also clinically associated with significant distress, such as not able to function in the school, impact on academic performance. So while we are talking about these criterias, why does it even matter that we need to pay attention to all these things? You have probably know by now that 60% of the adults report at least one adverse childhood experience, and 1 in 4 children experience maltreatment. And 45% of children have more than one adverse experience, and 3.5 million child abuse reports are done annually in the United States. So consider this is the data from CDC and SAMHSA. So considering that so much trauma is happening in the society, and for children, pediatricians are often the first point of contact for children experiencing trauma. And in addition, both male and females are at risk. 6% of females and 4% of male adolescents have known past 6 month diagnosis of PTSD, which is quite a significant prevalence for PTSD. And sample of white middle-aged adolescent, again 6% with a lifetime diagnosis of PTSD. And if you look at the minority population, Black and Latino young people have more exposure to adverse childhood experience and have greater symptom burden. Across all minorities, one of the things as clinicians we have to keep in mind, they are less likely to seek treatment for PTSD, which also make us even more hyper vigilant about screening for trauma in our youth with the minorities. And coming down to trauma-informed care, American Academy of Pediatrics, they recommend pediatricians play an important role in both in primary, secondary, and tertiary prevention of trauma and mental health disorder by providing trauma-informed care. But what is actually a trauma-informed care? It is defined by AAP as care that recognizes and responds to the impact of traumatic stress on children, caregivers, and service providers. It includes identification of children and families exposed to trauma, doing their assessment and intervention to support families after the event. And it's a big role to play for pediatricians, considering the impact that we have of trauma in our society. Timing is also important, as we talked about acute stress disorder versus it's a chronic stress. Is it a single event or patient has experienced multiple events? One thing to keep in mind is that not every child who get exposed to trauma will develop PTSD. Some children are resilient, and then some develop post-traumatic stress disorder soon after the initial event. In other cases, we have also seen that these symptoms develop way later on, at some later point, include PTSD in those when they found out something what wrong happened to them, or they came to know about all the memories that were repressed before. And those with prior exposure to trauma or other vulnerabilities, those could be the one that are at additional higher risk for developing the PTSD symptoms. And then children are certainly at a higher risk because of their limited ability to cope. Many times children may not have control on the situations, or they may not have enough support from the adults. So they're certainly at a higher risk to develop these trauma symptoms. And from a functioning perspective, it does affect their academic functioning, their social functioning, school function, how they function in the school and participate in the school. And also, PTSD is comorbid with a significant number of mental health disorders, including depression and anxiety. So, in regard to trauma, when children are exposed to ongoing trauma and support systems are not available, there is a or sufficient, not available or sufficient to restore a sense of safety and security, many developmental problems may result. And without treatment, the impact of these long lasting traumas can be very overwhelming, um, and it can last for long periods of time. So, chronic neglect, from the studies we have known that it does affect the development and structure and function of the developing brain. Our immune response system get impacted. Makes children more likely to shut down in interactions, or maybe become overly active in some relationships, which put them at a higher risk for bullying, rejection, and abuse. We'll talk more about how this can be interpreted more like an ADHD. And it also causes decreased trust in others that affect their ability to make long-term relationships, and leading to more social isolation and loneliness, and decreased hope for the self and the world, which become a trigger for later development of the depression symptoms. And if the children are young, it can also impact the development of language of emotions and decreased ability to cope with them. Again, more symptoms, mental health symptoms include low self-esteem, sense of learned helplessness. If they find themselves in a situation where they don't have much control and continue to feel angry and upset about the trauma either they are experiencing or their loved ones are experiencing. Less ability to buffer and incorporate the trauma in a way that allows the youth to move forward. They are more easily cued to negative and overreactive responses and reaction, which lead to conflict with the peers more often in the school. And many time it's even more worse if the parents and caretakers are also not emotionally available for them to process and buffer and protect. And or worse yet could be they if they are the source of the trauma or portray the world as unsafe, passing if the parents themselves they are the source of trauma and portray the world as unsafe, and passing on their anxiety and hopelessness to the child. So that's where our role as a clinician become acutely significant, to assess for these situations in when we are assessing the family, if the child need helps, or also being mindful about if the parent also need help in addition to the child.
Dr. Malhi, can I ask a
Mhm.
question about generational trauma? So
Yes.
looking at those adverse childhood experiences, the ACEs, is it helpful to, if you're looking at the ACEs for the child, again, to look at the ACEs for the parent as well, knowing that they may have some historical trauma from themselves as a child, much less, not just their adult experiences, but historical experiences that they may have that
Ye-
led to some of those concerning
yes.
or risky behaviors or
Hmm. Yeah.
so.
I think that that is a very, very good thought, Mindy, that when we are doing the assessment of the child, doing the assessment of the family in itself as a core unit would be really important because many of the ACEs that the child is experiencing at the time, the parents may have, definitely parents may be experiencing some of themselves at the moment, or they may have experienced even more before, which affect their ability to provide support to the children. So, how, as a clinician, we can address those ACEs to provide that trauma informed care? Now, I think that would be definitely the first
Yeah.
step before we even go into further treatments.
Great. Thank
Uh,
you.
mhm. And one of the things that we have to think about is that how primary care can provide the support and fill the gaps in this. Monitoring for vulnerabilities and signs, such as just Mindy was mentioning about the ACEs screening with the parents themselves, and then evaluation, anticipating for the child the possibility of trauma. If you are seeing any cues that you can pick on, that there seems like some suspicion for trauma happening, offer in advance that these issues can be faced with accomplishment, empathy, and understanding. That's one of the basic principles of trauma informed care. Asking directly regarding sexual abuse and other traumas, express these words in clinical context. Sometimes I have seen that in the first visit, if you can just get an overview, sometimes if the kid is new to your practice, they may not be able to tell you all the details and explain everything because there is a trust also, safety that they have to build with you. So just try to assess the if rather than the details, and telling the patient in words that I will not be asking a lot of details today may elicit an acknowledgement of trauma, that we understand that it may be tough for you. So whatever they feel comfortable, they can share, and then you continue your evaluation as you work with the child. So, to align with the primary care approach, pediatric traumatic stress screening tool adapted from UCLA brief screening for trauma and PTSD was designed specifically for our pediatrician to screen children for trauma, traumatic stress symptoms, and suicidality. So, we'll go over this pediatric traumatic stress screening tool, which has been tested, and there is a lot of data available from one of the things is was developed in Utah, and there is a lot of information available online as well. So you can look into more detail, but I'll go over some of the steps that they have recommended to follow. So, roadmap of care in preventing pediatric stress disorder in primary care setting. This is for 0 to 5, is using the Seek parent questionnaire at well visit. So it's available online in different languages, very easy to implement. What you do is you review the screening. It basically goes over all the social determinants of health and the community resources and things like that. So do the results indicate the social determinant needs? If yes, then it's acknowledge and ask and need and desire for more assistance. And if no, then you certainly continue to do that in the next visit. And if there is more need for the family, then they'll refer to the care management. So important is that first we acknowledge the social determinants or of health that may be putting them at a high risk for having a traumatic stress later on. Urgent need, engage the care team and provide the resources based on the situation. If it's non-urgent need, then consider engaging the care team, and based on that, whatever is required can be done. So this is available free version online. And then the next one is the screening for 6 to 18. So from 0 to 5, you do with the Seek R, which is primarily completed by the parent. For 6 to 18 is the pediatric traumatic stress screening tool, which I said was developed from UCLA brief screen for trauma and PTSD. And it has items, 2 items, 12 items, and 1 item, um, which will verify trauma exposure, any symptom clusters, and suicide screening. So they are also available in different versions, like parent report form from 6 to 10 and self-report from 11 to 18, and also has different branches, either low risk, high risk, what do you do, present in English. It's available in English and Spanish. And then it's also copyrighted clinical tool, but you can download the official copies from Intermountain Healthcare's website. So it was tested in Utah. So this is basically the two tools that are publicly available: pediatric traumatic stress screening tool for age 11 and above, and pediatric stress screening tool 6 to 10, which all the symptoms, there are 13 items. It talks about the trauma exposure, then it talks about the symptoms that could be because of the trauma, and also talk about the safety risk assessment. So, as we talked, multi-generational trauma is certainly one thing we have to keep in mind. The factors that can maintain this vulnerability that the trauma get passed from one generation to another. One is certainly genetic. There are certain mental health disorders certainly putting people at higher risk for experiencing trauma: bipolar, substance use, other mental health disorder. If they are positive family history, certainly those are the patients or the families you want to screen for any existing other trauma that the child may be experiencing. And then epigenetic, if there is, like during perinatal, any exposure to domestic violence or anxiety or fear, or even any in utero drug exposure, maternal depression, also should alert you to screen the patient for the trauma. And then environmental and behavioral is basically what you see in your clinical interactions as well: modeling one's family style of positive regard, respect, or denigration or abuse, aggravated by poverty, lack of social determinants of health, violence, racial injustice, all those environmental factors that can put them at a higher risk. So once you have your screening for trauma, one of the important things is that the symptoms can overlap with multiple other comorbid conditions. And one of the conditions is ADHD. And there are some overlapping symptoms of trauma that can look like ADHD, such as inability to focus, hyperactivity, impulsivity. And the way to differentiate from PTSD is the PTSD hyperarousal. If those symptoms happen usually when they get exposed to any trauma triggers or traumatic reminders. And always keep in mind, trauma history often precede ADHD symptoms. So ensuring, some patients could have both as well. So ensuring doing a full assessment to tease out symptoms because of PTSD versus because of ADHD could be the clinical, could be the way to address both the problems. And then depression, definitely one of the risk factor also. If you patient person has PTSD, higher chances of developing depression. Is the symptom primarily because of PTSD, or they comorbid? Something to keep in mind. So screening for both conditions, similarly for anxiety disorder as well. Screening for both conditions is important, but some of the symptoms of anxiety, if they are not meeting full criteria, could also be attributed to just PTSD as well. And ruling out bipolar, because irritability, aggression, mood swings can happen in PTSD as well, which is a common feature in bipolar as well. So is it episodic versus a reactive dysregulation on trauma reminders? That could be something to keep in mind. And then ODD or conduct disorder is something to keep in mind. Overlapping symptoms are aggression, defiance, rule breaking, and trauma-informed approach before labeling patients with ODD, ensuring that if PTSD is driving the symptoms, certainly getting the care for patient for PTSD symptoms can resolve some of the symptoms that can look like ODD as well. So this is the steps for intervention. This is a care process model that's developed based on pediatric trauma stress screening. It provides an example of structured step-by-step trauma-informed approach, which pediatrician can utilize during their clinical visits with the patients. And following the screening three-step approach, if definitely report, we are all mandatory reporters. So making a report for any abuse happening, current abuse happening. Also, safety risk assessment, which is also one of the questionnaires in PTSD scale. responding to that, and then stratify the treatment approach. So we discussed about the roadmap for 0 to 5. This is the roadmap for 6 to 18, in which you first screen with using the pediatric traumatic stress screening tool. And then if you have to report, call the DSF if there is an active abuse happening. And if there is active suicidal ideations, respond to that accordingly. And then if not, then third approach is stratify the treatment approach, inquiring about the symptoms, inquiring about their daily functioning, and then taking the next step. So if the score is coming out to be severe, then the approach which you will use is restorative approach, which is evidence-based. You will refer the patient for evidence-based trauma treatment, which is also called TFCPT. And if the symptoms are in moderate range, 11 to 20, you can refer, that approach is a resilient approach. You will still refer the child for therapy in the community, but they can do other type of CBT as well, or problem solving or supportive therapy that can provide them the coping skills to continue functioning at their maximum capacity. And if the symptoms are mild, then you go with the protective approach, which basically means that you provide strength-based guidance in your office and you continue to monitor the symptoms. So in regard to brief intervention, they also that screen also pick on if the patient is having sleep problems, hypervigilant or intrusive symptoms, avoidance, negative mood symptoms. So for sleep problems, idea is for all these symptoms, idea is first you use more non-pharmacological approach. And if that is ineffective, then there may be some options to consider medications as well. But those are always secondary. For sleep problems such as sleep education, meditation before going to bed, guided imagery, belly breathing, that can help relieve the anxiety because child may be having nightmares that can affect their ability to go to sleep, and they may be feeling scared. So using some of those techniques can help them calm down. And then we'll talk a little bit about the medicine part as well. And then hypervigilant and intrusive symptoms, again, helping them learn how to do belly breathing, progressive muscle relaxation, mindfulness when they're experiencing these symptoms. And in regard to avoidance or negative mood symptoms, yeah, behavioral activation can be important, like slowly getting them back to routine, helping the child how they can schedule maybe one outdoor activity and then slowly increasing it to two outdoor activities and bringing them back to what they were functioning before. And then continuously follow up at a regular intervals and coordinating the care based on their response. So report if required. I think you all are very well aware of it. I will not go into much detail about it. So calling DFS, Delaware Child Priority Line or Crisis Line, if you feel that there is active abuse happening in the house, or even if there is a history of abuse that has happened in the past. And then we leave up to the DFS to investigate and further do their further next steps. And suicide risk assessment, I think we have done training on suicide risk assessment as well. If it's a low risk, consider referral to mental health plus patient education. If it's a moderate risk, there are thoughts with the method, no specific plan. Then assess the risk factors, complete a safety plan, and then 24 to 48 hours if the patient does not meet the criteria to go to inpatient, but inpatient could also be considered based on the risk factor in this category. In high risk plan, where there is an intent, either with or without plan, that's where you immediately get to the next level, going to the emergency room, crisis center, or one of the inpatient facilities in the state to get further help. Keep in mind, suicide is also a significantly leading cause of death in Delaware. Suicide is like leading cause of death in Delaware as well, and early connecting our children earlier can prevent those numbers. Stratify the treatment approach, which we talked about, either protective, resilient, or restorative, which I have gone a little bit in just a few minutes ago, in which you mild is more strength-based, resilient is more where you definitely make a referral for community health therapist, and then restorative is where their symptoms are very severe and they need evidence-based approach, which is a trauma-focused CBT, and we'll talk about in a couple minutes. So this is again the details of the scale. Question number one talks about sleep problems, and again, question number one and two are sleep. 3 to 7 talk about hypervigilance and intrusive symptoms. 8 to 12 is avoidance and negative mood, and number 13 is for the suicide screening. And then matching with the symptom cluster, we have talked briefly about non-pharmacological interventions, which is more like education and some meditation or belly breathing, mindfulness. Those are the techniques that can be utilized to address these symptoms. In regard to sleep, if none of those non-pharmacological interventions work, currently we do not have any FDA-approved medications for pediatric trauma symptoms, including sleep. Melatonin can be considered in certain situations. There are studies for prazosin as well. It's not FDA approved for nightmares, but very commonly utilized, keeping in mind that it can impact the blood pressure. Starting low and slowly going up on gradual titration would be beneficial to monitor any physiological impact on the vital signs or blood pressure. And but it does help with the nightmares and can help improve the quality of the speech as well, sleep as well. And then you use using other sleep hygiene activities such as reinforcing sleep healthy schedule, limiting the screen, fluids, caffeine, or teaching them to use some mindfulness before going to bed can all be very helpful yeah, before we try the medications. When to consider medications in PTSD is like when there is a severe agitation, self-injurious behaviors, significant impairment after trial of behavioral intervention, and there are poorly controlled psychiatric. I think there is some background noise coming in. Okay. Poorly controlled psychiatric comorbidities such as severe anxiety or depression, or even if ADHD is a comorbidity, you have to keep those conditions in mind. And then treatment, if it's a treatment refractory insomnia, you have done sleep hygiene, you have done other interventions like non-pharmacological interventions, and none of them have been effective. And then poor access to evidence-based psychotherapy, which is one of the things that we experience in our state, is that we have more people to serve but less providers. So sometimes they may not be able to get to the evidence-based professionals, TFCBT, trained professionals who can give them the treatment. And what do you do in that cases if the patient is significantly suffering? So medications can offer some symptom relief, but certainly not the first line. Some of the medications like SSRI can be helpful if there is a comorbid depression, anxiety symptoms. As I said, prazosin has showed some benefit with improving nightmares in children and adolescents with a range from 1 to 4. I've never gone beyond 2 milligram. Usually it has been beneficial up to that range, but you have to monitor the blood pressure very, very carefully and cannot stop the medication just cold turkey. It has to be slowly tapered off so there is minimum impact on any blood pressure. And then alpha 2 agonist clonidine, guanfacine can also, some studies have shown, can be helpful for hyperarousal, vigilance, or irritability. But again, they are also not FDA approved medications for PTSD. And beta blockers, propranolol has shown some benefit with physiological reactivity. And mood stabilizers. There are studies, some studies with mood stabilizers as well, Depakote, gabapentin, usually when there is a significant impulsivity, aggression, or irritability associated with PTSD. Antipsychotics generally not recommended unless there is a comorbid bipolar disorder or any other psychotic disorder also present in the pathology of the patient that we are seeing. Also have to be very mindful of using antipsychotic because it requires consistent metabolic screening with A1C and lipid profile, which has to be done 3 months after starting medications on a yearly basis after that. And there is a significant side effect with many antipsychotic for the weight gain, which you have to monitor very closely, especially when initiating the treatment in the beginning. So this is something I just talked about. Polypharmacy is very common in lower income youth, especially in the foster care or residential facilities or juvenile system, just because of our fragmented healthcare systems and fragmented systems of care, where patient is not under one provider for significant time to manage their medication. So they keep on going to different people, which then end up having more and more medications in their regimen, and reassess the need for medication at every visit. One of the things is that we always have to stay mindful which medicine is working, which is not working, and continue to reassess which medication can be tapered off, because we know that majority of our psychotropic medications do come with burden of the side effects. Replace rather than adding when you have a low response rate to medications. And psychoeducational medications, including discussion of risk and benefits, is very important, especially with certain medications like prozosine, clonidine, can have impact on blood pressure if they are discontinued, discontinued without any consultation with the clinician. And then if we go further into evidence-based treatment, which was the approach we recommend if someone has a severe PTSD symptoms. And the evidence-based approach has been TFCBT, which is approved for pediatric patients as well. Lots of studies have been done. It shows significant positive outcomes, usually done in outpatient settings. And the second one is PCIT, which is parent-child training interaction, can also be helpful, that improve the positive parent interaction with the child between age 2 to 7. And then there is a child and family traumatic stress intervention, a brief early outpatient intervention for recently traumatized youth and caregivers. So care coordination is very important, 2 to 4 weeks checkup to catch if there is early worsening and confirming follow-up with the appropriate referral. And then again, continue to recheck the symptoms on a 4 to 6 months basis as well, because we did talk about the delayed onset of PTSD, which can also happen in our patient population as well. So key takeaways in this case is just prevent early, use the Seek questionnaire, screen for the any traumatic events at 0 to 5 age group so that you can catch before the family even get to the trauma. Broadly screen pediatric patients to cover the exposure, symptom, and suicide risk. And then we talk about either having a protective approach, resilient, or restorative approach. You can focus on, I know the visits with the primary care can be very short, and you have to keep up with the pace with back-to-back patients. One of the things you can do is, if you notice there are sleep problems, there are hypervigilance, there is avoidance, you can pick one symptom during one visit and address that cluster, and then maybe focus on the other cluster in the next visit. So I think maybe teach one skill at a time. If the patient is able to implement that skill successfully, at least we have achieved some in our treatment strategy. And then individualize the care. When the symptoms are severe, you have to think about what evidence-based approach is for PTSD, which we talked about is TFCBT or PCIT or child family stress intervention or other specialized trauma treatment to address before the symptoms start developing more comorbid conditions. And briefly about trauma-focused CBT, it's a prescribed but flexible sequence. This is how it goes: psychoeducation, then relaxation, affect expression and modulation, which is basically we tell the patients how to learn about when they are feeling certain emotions, naming them, and then cognitive coping, developing the coping skills, and then the therapist go into trauma narrative, which is the main significant middle of the treatment section, in which you talk about in detail, in depth, the trauma the child has experienced, and then in vivo gradual exposure based on what the trauma has been. And there are some conjoined parent session as well. It does require individual and parent sessions together, and then also enhancing safety because feeling loss of trust and safety, sense of safety is the one thing that we commonly see in patients who have experienced trauma. And this is the usual TFCBT workflow. Normally, 1 to 4 sessions are focused on psychoeducation, relaxation, affective expression, and coping strategies. Then, in between session, as I said, either trauma narrative or in vivo gradual exposure. And then at the end is the conjoined parent sessions and enhancing the safety. And then we terminate the therapy and continue to have follow up as needed as needed after the therapy has ended. And it involves child education, parent education, and then joint sessions as a family with the parent and child together. And TFCBT basically help in cognitive processing of the trauma for the children. So think about like an elephant in the room by giving it the trauma a name, telling them they are not alone, teaching them to breathe, showing them they can tell their story, showing them how that we can hear their story. We provide that psychological space for children to express their emotions and showing them that the people who love them can hear it too, which is main primary focus of doing the parent and the conjoined sessions. Multiple narratives. These are some just very few examples. Multiple narratives come up through the trauma CBT. Um, Examples could be, I don't know why I did it for sexual abuse, physical abuse. She hit me because I was bad, like blaming themselves, or domestic abuse. My mom didn't care. Serious accident. I couldn't help her. I was just too petrified if they are involved in any accident, or drunk driver never gets hurt. Why we get hurt? Traumatic death could be blaming themselves, not helping out the loved one they have lost. And this is the when to consider to refer to a child psychiatrist is when there is active, like symptoms are severe, in which can include such as active suicidal, homicidal ideations or plan. In with that case, you will also consider high level of care, such as inpatient psychiatry, or there is a psychosis, severe dissociation, or very, very severe symptoms of a PTSD. There is a comorbid substance use also, or there is a treatment resistant depression, like you have done 2 or 3 medications, nothing is working out. And then that could be also a good way to consider child psychiatrist assessment be done, or complex trauma history with multiple placements. Or another could be diagnostic uncertainty. Sometimes these symptoms can look like bipolar, or could be ADHD, or could be ASD, autism. So how do you, like, you have done the best you could in the time that you have, and you want an expert opinion? That could be another situation when you want to consider a child psychiatrist referral. A need for pharmacotherapy beyond primary care scope, like 1 or 2 medications you have done, and now that it's becoming complex pharmacology, you have requiring 3, 4 medications, but still symptoms are not improving, or severely impaired family or caregiver functioning, where you're having challenges to engage the family in the care. Important is to bridge that care, and I think that's where DCPAP also comes in, where you can have while the care get transferred to child psychiatrist, or even if you feel that in the meantime you are the one can take care of the family and they can't make it to child psychiatrist because of any number of reasons, having the DC PAP support from child psychiatrist could be very beneficial and can be helpful in that way. So, so that would be something to keep in mind. And these are some of the references. So that concludes the presentation for today.